Hello and welcome back to my channel. If you are watching this, you are studying for the PANCE or PANRE and looking for a musculoskeletal review. I'm here for you. We're going to continue our discussion today on upper extremity weakness. If you haven't seen parts 1, 2, and 3, I'm going to put a link in the description below. So let's get back into it. Well, let's start with cervical radiculopathy. Cervical radiculopathy. What is it exactly? So let's draw our fake patient here. Here is our arm, our elbow, and let's draw a hand here. So you have a brain, spinal cord, and the spinal cord will give off these nerve roots that go all the way down into the hand. And if you have some sort of lesion that irritates these nerve roots, you get pain, numbness, weakness, paresthesias in this distribution of that nerve. We call that dermatomal. So this dermatomal findings of symptoms is what will define cervical radiculopathy. Here is our spinal cord we're going to draw again with our exiting nerve roots here. And what is in front of this spinal cord is going to be a bone, like a vertebral body, or a disc with this nucleus pulposus and the annulus fibrosus. And what most commonly happens with radiculopathy is that this nucleus pulposus will herniate out and irritate this nerve root. This can happen in young patients in an acute form. It can happen in an elderly patient when the discs become dried out and degenerative, and that can cause radiculopathy. On the physical exam, again, this is a lower motor neuron lesion, so you will get the lower motor neuron signs, hyporeflexia, weakness, atrophy in the late stages. The provocative exam is the Sperling's exam. So how you would do that is you have the patient turn his or her head, kind of angle it to the side here, if that makes sense. And if you put pressure on the head, what that does is that compresses the cervical spine on that side, and a positive sign is reproduction of the dermatomal findings on that side. Our treatment is our health insurance algorithm, which includes a PT exercise program, plus or minus anti-inflammatories for the symptomatic relief. If that does not work and they still have neurologic symptoms, you will get imaging. The imaging is an X-ray and an MRI. The MRI will show if there's a soft tissue lesion compressing that nerve root. And depending on that finding, you will send to a spine surgeon. So what if they have numbness and tingling in their upper extremity and hand, and that is not cervical radiculopathy? Well, the most common problem will be the peripheral mononeuropathies, namely the median nerve and carpal tunnel neuropathies. So let's get into that. So the two main peripheral neuropathies you will find, the peripheral mononeuropathies I should say, or the median neuropathies and the ulnar neuropathies. So let's draw another hand here. And this is the palmar side of the hand. Very simply, the median nerve will innervate the thumb, the index finger, the middle finger, and just half of the ring finger. That will be your median nerve. And the ulnar nerve, let's draw this in maybe pink. The ulnar nerve will innervate the small finger and half the ring finger. And we'll draw the rest of the forearm here. Now the median nerve will travel down from the elbow into the forearm and will dive into this tunnel called the carpal tunnel. And that is the most common site of compression for the median nerve, is the carpal tunnel. And what overlies this carpal tunnel is this very thick ligament called the transverse carpal ligament. anything that will increase the pressure on that nerve will cause these symptoms. And this can be caused by several things, one of which is simple flexion of the wrist. So wrist flexion can cause increased pressure. And when do most people flex their wrist without knowing it? Well, when they are sleeping. So a lot of people sleep in the fetal position, so when they flex their wrists, they are increasing the pressure in their carpal tunnel, causing those symptoms. Pregnancy, in which there are a lot more fluids in the body, there's a lot more swelling in the body, that can increase pressure in this carpal tunnel space. A fracture can break off and displace and push into that nerve as well, particularly distal radius fractures. So if you imagine there's a distal radius under here, if that fractures, it can push on that carpal tunnel. And the other risk factor is having diabetes. So for some reason, diabetics seem to get this more often than non-diabetics. On the physical exam, now technically this is a lower motor neuron lesion. There are no deep tendon reflexes for the median nerve at this level, but you do get the atrophy and the weakness and the fasciculations if you would get a nerve study. But in order to test this nerve, in general, there are 3 ways to do it. You can tap on the nerve, you can compress the nerve, or you can stretch the nerve. When you tap on the nerve, you just get your finger, you just tap, tap, tap here. We call that a Tinel sign. You can just push on the nerve, just provide compression. And the guy that described that, his name was Durkin, so we call that Durkin's. That seems to be the most specific and sensitive test for carpal tunnel syndrome. And the last one is taking advantage of this flexion of the wrist. So if you flex the wrist for long enough, you can reproduce the symptoms. And of course, the guy that described that is called Phelan, so we call that Phelan's sign. Again, you'll get atrophy of the median nerve innervated muscles, and that will be the thenar muscles here in this part of the hand. And they will get weakness in things like gripping or anything, opening a bottle. The diagnosis for this is clinical. You can make a diagnosis clinically, but it is often very helpful to get a confirmatory diagnosis. So a confirmatory diagnosis is a electromyogram or EMG and a nerve conduction study. It's not very pleasant. You put pins and needles on someone's fingers and skin, and it measures how well that nerve is performing. Now that you've had your diagnosis of carpal tunnel, what is the treatment? Well, the first thing you try always is stop the wrist from flexing. You want to take advantage of this. You want to reverse the Phelan sign essentially. So you brace the wrist. Second thing you can try is an injection. Now this does not cure carpal tunnel, but it can provide symptomatic relief for quite a while. And it also is a diagnostic injection. If they have good relief from the injection, then it's very likely they will get good relief from the third treatment option, which is surgery. And all you do is you simply release this transverse carpal ligament and unroof the carpal tunnel, and that relieves the pressure on the nerve. Now say you have a patient with numbness and tingling in this side of the hand. It is not cervical radiculopathy, as in you don't have the radicular symptoms. You don't have the Sperling sign. You also don't have these provocative carpal tunnel signs. You don't have a Tinel's in the wrists. You don't have a Durkin's or a Phelan's. Well, there is another syndrome that can compress the median nerve. It is rather rare, but you may be expected to know it on this exam. Is the Pronator syndrome. So the muscles that run in the forearm that pronate the wrist and forearm are called the pronators, and the median nerve dives between them. So if you pronate the arm and you reproduce their symptoms, or anyone that has very strong pronators, think bodybuilders, you can get median nerve compression in the forearm, which is called Pronator syndrome. Just something to keep in mind. Treatment for that is trial of PT and surgical release. All right, well, let's move on to ulnar nerve. Now, ulnar neuropathy is also known sort of as the funny bone. When you hit your funny bone, you're actually hitting your ulnar nerve. So let's draw our little funny bone. So this is our distal humerus. Here's our humerus. Here's the joint. The medial side of your humerus has this little extra bump here. We call it the medial epicondyle. Medial epicondyle. You can actually feel it right now. If you feel on the inside of your ear, well, there's this little bump, and that's the medial epicondyle. And to be honest, I don't really know the purpose of this other than to protect your funny bone or protect your funny nerve, because under that medial epicondyle is your ulnar nerve. I'm going to draw the rest of the forearm and a hand. This is someone's thumb here. So the ulnar nerve will start above the elbow, dive under this medial epicondyle, continue its way to the ulnar side of the hand. This little area under the medial epicondyle is also covered by a ligament. You don't need to know this, but it's called Osborne's ligament, and it makes a bit of a tunnel, which is why we call compression here cubital tunnel syndrome. And that is the most common site of compression of the ulnar nerve. So with ulnar neuropathy at the cubital tunnel, you will get pain, paresthesias, numbness on the ulnar aspect of the hand and the forearm. So paresthesias, numbness, weakness. And what exactly is weak? What in the hand, the upper extremity, will get weak with compressive neuropathy of the ulnar nerve? Well, for that, you have to know the anatomy of the ulnar nerve. And the most important muscles it innervates are the interosseous muscles. And so what the interosseous muscles in the hand do is abduct and adduct the hand. And well, most people don't go around saying, I have weakness in my abductors of my hand, but they will notice they cannot pinch as well. The best way for me to describe this is just to show you. So I'm going to flip my camera and show you what I mean. If you take your hand, the ulnar nerve is responsible for abducting your fingers and adducting your fingers. And when you pinch something, particularly with your thumb and your hand, that is activating this first set of interosseous muscles. So if you get a patient to try to pinch a piece of paper, if they have ulnar neuropathy, you will easily be able to take that paper out of their hand. Interestingly, one way you can adjust for that if you don't have a good ulnar nerve is to use a compensatory muscle such as your flexor pollicis longus, or the flexor of your thumb, which is innervated by your median nerve. So this is a sign, flexing that thumb, of ulnar neuropathy. And we actually call that Froment sign. Some guy named Froment described this sign for ulnar neuropathy, and that is something that can be tested on the PANCE. So on a physical exam, you will get the sensation problems in the ulnar nerve distribution. You will get the weakness of pinching, abduction, adduction. The named sign is Froment sign. And in the end stages, you get atrophy. And so you'll get atrophy of the muscles in between the bones of your hand, in between the metacarpals. The other way to test the ulnar nerve is similar to the provocative tests for the median nerve. So one, you can compress the cubital tunnel. So you can actually push on the cubital tunnel. So you can tap on the cubital tunnel. That's called the Tinel sign. And you can flex the elbow. And the reason is when you flex the elbow, you're actually pulling that ulnar nerve taut. And again, I think it's easier to show you. So I'll flip the camera one more time. Now let's pretend this string is my ulnar nerve, and it will wrap around the medial epicondyle here. Now if you notice, when we start, the nerve is nice and loose and flexible. But as I flex up my elbow and the nerve catches my medial epicondyle, that nerve is now taut. So now it's loose. And if you flex up, it gets taut. So loose and taut. That is why when you flex the elbow and you have cubital tunnel, you can get these symptoms. So think of someone talking on their cell phone. Think of someone holding up a beer can for a long time. Again, the diagnosis is clinical, and the EMG nerve conduction study can be used for confirmatory diagnosis. Now, treatment, the corollary to carpal tunnel of wrist bracing would be elbow bracing. So if you brace the elbow at night, you can help symptoms. As always, physical therapy, stretches are an option. Injections are not an option for cubital tunnel, so no injection. But surgery is. So one is an elbow brace, and then second essentially would be surgery. Our next cause of upper extremity numbness and weakness is thoracic outlet syndrome. Now, thoracic outlet syndrome is rather rare. It is difficult to diagnose, and it is difficult to treat. So therefore, every test always loves testing it. I don't really know why. Now, what is thoracic outlet syndrome? Let's draw our patient. Here is the head. Here is the thorax. The outlet of the neurovascular structures coming out of the thorax is called a thoracic outlet. And what comes out of this thoracic outlet? Well, it is one artery, specifically the subclavian. It is one vein, which would be the subclavian vein, and a plexus of nerves, so a sort of nerve plexus. It's called the brachial plexus. And it's somewhat helpful to know the borders of the thoracic outlet because it'll help you diagnose this on a test in real life. One of the borders is simply the muscles, called your scalene muscles. People that are very hypertrophied, so think CrossFitters, muscle builders, or weightlifters, their scalene muscles will be very hypertrophied. The bottom of it is sort of bordered by that rib, the very first rib, which will come around here. So that rib will be below here. Another very important structure in this part of the thorax is the lung. So the apex of the lung here also is very close to that thoracic outlet. And finally, what sort of forms the roof of this is the clavicle, so the collarbone. So think collarbone above, or clavicle. Think rib, lung below. And think the scalene muscles around it. So that is sort of a simplified version of the thoracic outlet. And compression of any or all of these will result in symptoms. Now, the key differentiating factor between the nerve symptoms in thoracic outlet versus cervical radiculopathy and all the other modern neuropathies is that it is non-dermatomal. And the other thing that's unique about thoracic outlet, especially on an exam, is that they will usually include vascular problems as well. So if it's the subclavian artery getting involved, you'll get some sort of ischemic symptoms like pulselessness, maybe a Raynaud's type syndrome. And if it is the vein, you will get congestion, venous congestion. So on an exam, they would have to show you some patient with this non-dermatomal weakness, numbness, pain, and usually some vascular phenomenon as well. Physical exam is once again quite confusing, but essentially you are finding a way to compress that thoracic outlet. You, for example, push down on the clavicle. If you're pushing down on the clavicle, so pushing down here, that will compress the thoracic outlet. So compression of the clavicle. So you have them take a deep breath. So inspiration. At the same time, you are abducting their shoulder and externally rotating their shoulder. External rotation, plus abduction. If you imagine that is pushing upwards on the thoracic outlet, these maneuvers. And if you check their pulses, you check their symptoms, you check their venous congestion, if it reproduces those symptoms, that is a sign of a thoracic outlet syndrome. There is no radiographic or MRI or any other finding that will prove this is thoracic outlet syndrome. Some people do have a cervical rib which is an extra rib, but most people don't. The treatment, once again, is vague and generally unsatisfying. So you can do physical therapy and exercises. And there are various surgeries you can do, most commonly removing that rib. Moving first rib. And let's finally get into our final two causes of upper extremity weakness, my favorite topic, which is shoulder pathology. Let's start with rotator cuff. What is it exactly? Well, the rotator cuff are a series of tendons that move the shoulder around. And you've probably at least heard of the mnemonic SITS, which represents the forward tendons. They are the supraspinatus, the infraspinatus, the teres, and is it the minor or the major? It is the minor. And last but definitely not least, and some argue the most important, is the subscapularis. Now there is a helpful way to know where these are positioned on your shoulder, and I will flip the camera around again and show you. So I read this in a book called Orthopedics Made Ridiculously Simple, but if you take your hand and you grab your own shoulder like this, you can represent where those tendons lie on your own body. Starting with the middle finger is where your supraspinatus tendon is. The ring finger is where your infraspinatus is. And your small finger is where your teres minor is. If anything, this will help you remember that the teres is a minor, not major. And your thumb represents your subscapularis. Your subscapularis is on the anterior part of your shoulder. And I know you're asking, well, what's your index finger? Well, the index finger is your biceps. The short head of the biceps tendon actually is very intimately involved in your rotator cuff. So that's what this little mnemonic helps you remember. Now, the exams for this are very important. That's probably what's most tested on the PANCE. So for the supraspinatus, which is my middle finger here, the most important job is to abduct the shoulder or raise the shoulder. And so the provocative exam is to, number one, ask them to abduct the shoulder. Weakness and pain with that motion will be positive supraspinatus sign. On the test, for some reason, they like to talk about the Job, which is simply abducting your shoulder with your thumb down. They call this the empty can sign. And another one is the drop arm. Again, you start with your arm in the air and you slowly lower it. And if your supraspinatus is weak or torn, it'll be very painful and your arm will simply drop to the ground. Now when it comes to the infraspinatus exam, the infraspinatus, which again is your ring finger, and if you imagine what that muscle is doing, it is externally rotating your shoulder. So to test the infraspinatus, you need to externally rotate against some sort of force, and weakness and pain is positive for the infraspinatus. The teres minor is also an external rotator, with the difference is you're rotating with your arm elevated. So when you externally rotate in this position, this is your teres minor. People call it the hornblower sign because I suppose if you're going to play a trumpet, you need to use your teres minor. And finally, the subscapularis, which like we talked about, is in the front part of your shoulder, and that is why it is an internal rotator of the shoulder. Now, it is a little tricky to test that, which is why we have all these strange exams, one of which is the belly press. So if you internally rotate, eventually you're going to hit your belly. Now, someone with a torn subscap, when they try to push on their belly, they are not strong enough, and so their elbow will fall back. And that is a positive belly press. If you continue your internal rotation of the shoulder and go through your body, eventually you will end up with your hand on your back. And so another test is the lift-off test. If you bring your hand off your back, that requires very strong subscapularis function. If you can't do that, that's positive for subscapularis tear. So let's go back to the board. So as a review, the supraspinatus is going to abduct the shoulder. The infraspinatus externally rotates, as does the teres minor. But remember, the teres minor is in elevation. And the subscapularis is your big internal rotator. The other key physical exam finding for rotator cuff is on top of these provocative findings, your passive motion is normal. This differentiates between rotator cuff tears and a pathology called frozen shoulder and shoulder dislocations. With frozen shoulder and dislocations, a passive exam will not be normal. Well, the diagnosis for this is an MRI. The only way to diagnose a rotator cuff tear is to look at the soft tissue. So an MRI is the best choice. If they cannot get an MRI, there is something called a CT arthrogram, in which you inject dye into the shoulder joint. If dye leaks out of the shoulder joint through a rotator cuff tear, you will see it on the CT scan. Now, our treatment. Now, you usually can start with a trial of physical therapy and home exercises. Injections are actually slightly controversial. Because number one, it does not help cure the problem. It's just there for pain relief. And in fact, it might slow down rotator cuff healing. So the current recommendation is maybe one injection. And finally, if they have a tear and they have failed this conservative treatment, surgery. Moving on to shoulder dislocations. In order to understand dislocations of the shoulder, I think it's really important that you understand what a shoulder x-ray will look like. And for that, I think it's very helpful to be able to draw it. So I encourage you to get out a piece of paper and pen and follow along. If I were going to draw a humerus, so this is going to be a right humerus, there's the articular portion here in the neck, and there's a little bump here called the greater tuberosity. It's very important to find that on an x-ray. The socket side, if this is the ball side, the socket side, when you're looking at an AP, you will actually see the sort of oval circle of the glenoid. And the other thing I'd like you to be able to draw is a little bump here, which is called the coracoid. The coracoid is sort of the lighthouse of the shoulder. There's another important view you will need to know, and that is called the scap Y. So this is a 2D image, but if you imagine in your two-dimensional mind to spin this 90 degrees, so you're looking face on the glenoid. So now this is the glenoid. You're looking straight at it. It looks sort of like a pear. What you have going out the front is the coracoid, and it looks sort of like a beak. I'd like you literally to draw this. And on the other side, you have the acromion. It looks something like this. The bottom of the Y is the body of the scapula, which is something like this. But this is the Y. So if you're thinking of a scap Y, this is the Y which we are referring to. Now, a normal position of a humerus is going to be right in the middle of the Y. And a dislocation will present either in front or anteriorly, or in back or posteriorly. So it's very important you'd be able to look at an x-ray on this exam and in real life and interpret when the humeral head is on the glenoid or when the humeral head is anterior or posterior to the glenoid. Now let's start with anterior dislocations. If you think of a shoulder dislocation, anterior is by far the most common. And it is almost always going to happen with a trauma. And there is an easy way to remember the position of this. If you imagine yourself throwing a baseball, if you're rearing back to throw a ball, that is a position of a anterior shoulder dislocation. So if you picture this is you or the patient, the arm is going to be abducted, the elbow is going to be flexed, and they're maybe holding some sort of baseball here. That is the position of dislocation. It's an abducted and externally rotated shoulder. This will present with pain mostly, but yes, weakness. And I bring this up because I saw a test question that started the question stem with patient presented with shoulder weakness, and it ended up being a dislocation. Physical exam, like we said before, they will not be able to move their arm either actively or passively. And another important part of the exam, again, it helps if you can be a little bit of an artist and draw along with me. So a normal shoulder contour will have a collarbone, and we'll have an acromion like this. And the other thing that we'll have is the humerus along with its greater tuberosity. And the glenoid is something like this. The normal contour of someone's shoulder is very rounded like this. It's got a very nice shoulder contour. Now when you have a dislocation, let's draw this again. You have our clavicle and our acromion. When the shoulder dislocates, the humerus is no longer where it should be. The humerus is maybe somewhere over here, anteriorly dislocated. So now your shoulder contour is no longer normal. You have a sort of step off or squaring off. What's called a sulcus. We call it the sulcus sign. And the shoulder will be almost like a point, or they call this squaring off of the shoulder. And so this asymmetry is what is going to point you towards a shoulder dislocation. Again, the diagnosis is going to be x-rays. X-rays are going to show this dislocation. And let's draw it again. Let's draw a glenoid. So this is going to be our glenoid here. A little oval. We're going to have our little scapula and our coracoid here. And the humerus will not be on the glenoid. The humerus will be maybe somewhere over here with the greater tuberosity right here. So when the head does not match with the glenoid, that is an anterior shoulder dislocation. The treatment is a stat reduction. Stat reduction for two reasons. Number one, the longer you wait, the more difficult it is to reduce this without having to take them to surgery and make a large incision on their shoulder. And two is that when this shoulder is out of the socket, the blood supply that is feeding this humeral head is getting compromised by the minute. And if the humerus loses blood supply, you get something called avascular necrosis of the humeral head, which is a very, very difficult problem, almost impossible problem to treat. It is very important on the PANCE to know the secondary injuries when it comes to anterior dislocations. Secondary injuries. Most important one is the axillary nerve. The axillary nerve is a nerve that lives literally right under this humeral neck here. You can actually feel it during shoulder surgery. So it's very easy to stretch this out during a shoulder dislocation. Axillary nerve dysfunction will present numbness and tingling in this axillary nerve distribution here in this part of the shoulder. 2 is going to be a rotator cuff tear. So when your shoulder is sort of out of the socket, if it doesn't stretch, it's going to tear. 3 is a labral tear. The labrum, which I will describe in a later lecture, is a little rim of cartilage that forms around the glenoid. So this is your glenoid. It's actually a rim of soft tissue around the glenoid that we call the labrum. And the last secondary injury you should be familiar with is what's called the Hill-Sachs and Bankart lesions. And to demonstrate this, I will draw another glenoid. So this is our glenoid, and this is our axillary lateral view. So this is a top-down view. The coracoid is anterior. This is posterior. Now what happens when you dislocate a shoulder anteriorly, the humerus will hit onto the glenoid like that. And it makes this little divot here. And so you get damage on both this humeral head and on the glenoid. We call the humeral lesion a Hill-Sachs. I don't know why we don't just call it a humeral divot, but some guy named Hill-Sachs wanted to name it after him or herself. And on the other side, on the glenoid side, we call that a Bankart. I wish we would just call it a glenoid lesion, but no, we have to call it a Bankart lesion. And finally, let's move on to what I call the snake in the grass for shoulder pathology. When a patient comes in with shoulder pain, weakness, when I trained, there was a chief resident who always talked about what is the snake in the grass, what's going to burn you. And what's going to burn you with a patient with shoulder pain and weakness is a posterior shoulder dislocation. So let's talk posterior dislocation. And the reason it's a snake in the grass is because a lot of times the shoulder x-rays will look rather normal. I say rather normal because if you know what you're looking for, you won't miss it, and I will show you that today. The risk factors for this posterior dislocation are things you need to be looking out for on the exam, and those are seizures and electrocution. Posterior dislocations are very unusual, so unusual it requires an unusual mechanism. And if you think seizures, don't think of just your person that stopped taking their seizure meds. Think of an alcoholic on a test, someone that is in alcohol withdrawal seizures. Think in your OB rotation. If a patient has eclampsia, has preeclampsia, and then goes into seizures, they can wake up with a posterior shoulder dislocation. So let's draw another x-ray together. So here's our glenoid. Looks like a little oval. Here's our coracoid. Looks something like that. And here's our scapula. Now if I was going to draw a posterior shoulder dislocation, I would draw the humeral head. Now I'll draw the other half of the humeral head like this. If you notice, I did not draw that little bump. I did not draw the little bump that is the greater tuberosity of the humerus. This unusual finding occurs when the humerus is dislocated and spun 90 degrees. So you are not looking at it face on. We call this the light bulb sign because it looks like a light bulb. And when you see the light bulb on an exam, the light bulb in your head should go off to posterior dislocation. When you suspect a posterior dislocation, the first thing to do is more imaging. You have to get better imaging, whether that is a scap Y view or what's called the axillary lateral view, in which you look a top-down view, or a CT scan. So X-rays or a CT scan, and that will confirm a posterior dislocation. The treatment, once again, stat reduction. And the same secondary injuries apply: axillary nerve lesions, cuff tears, labral tears. The only difference being the Hill-Sachs and Bankart lesions will be reversed. So if you have a glenoid here and a coracoid here, a posterior dislocation, again, this is anterior, this is posterior, this way is lateral. A posterior dislocation will result in the humerus sort of hitting and latching on to this part of the glenoid. So you will get a Hill-Sachs on the humerus, a Bankart on the glenoid, and we simply call this a reverse Bankart and a reverse Hill-Sachs when it's a posterior dislocation. So we've done it. We've completed our discussion on upper extremity weakness / numbness. I really hope this is helpful. My name is Will Kang. I'm an orthopedic surgeon. I'm here to help you pass the PANCE. Please subscribe. Please follow me along for more videos.